Fractures of the distal forearm are commonly seen in emergency rooms, urgent cares, and primary care clinics. While non-displaced or mildly displaced fractures can be splinted and referred to orthopedic surgery, grossly displaced fractures should be reduced in a timely manner. This can improve the patient's pain and reduce the risk of fracture fragments pressing against neurovascular structures and causing further injury. Extra-articular fractures that are dorsally angulated or displaced are known colloquially as Colles fractures. Extra-articular fractures that are angulated or displaced in a volar direction are known as Smith fractures or reverse Colles fractures. The closed reduction may be done under sedation, but is often done under a hematoma block. Skin over the fracture site is cleansed and prepped. A needle is introduced into the fracture hematoma. If the fracture occurred within the past few hours, drawing back on the plunger will reveal a flash of blood if the needle is in the hematoma. 5 to 10 milliliters of a local anesthetic, such as 1% lidocaine, is injected. Once adequate anesthesia has been obtained, a reduction maneuver can be performed. With one hand, the clinician grasps the patient's hand. The patient's forearm is held with the other hand. Traction is applied across the wrist. In this Colles fracture, attempts to pull the distal fragment in a volar direction are unsuccessful because it is hung up on the proximal fragment. In order to pull the distal fragment over the edge of the proximal fragment, the fracture angulation must be accentuated. Now, with traction and volar force, the distal fragment is pulled into place. A sugar tong splint is applied. Three-point molding is used to prevent the fragment from falling back out of alignment. Sensation, motor strength, and capillary refill are reassessed to ensure that neurovascular structures are intact. Post-reduction x-rays are obtained to evaluate the fracture alignment.